Thank you so much, Cheryl, and thank you everyone for joining in and spending the little bit of time this afternoon with us. Really appreciate it. So my name is Amit. I'm a pediatric gastroenterologist who trained in the UK in the NHS, and I finished my training in 2017. Came to Australia in 2018. I went and joined the Melbourne Children's Hospital as one of the gastro consultants there for a year. And then my wife got a job in Perth, so here I am. So for the last couple of years, and so I have a public appointment at St John of God in Midland Hospital in public peds side of things, where I do some peds gastro as well. But I do my private work in Wembley, in Perth Gastroenterology and Liver Care, and in Wexford, Murdoch. So a couple of places where I do my private work as well. And thank you for giving me this opportunity to share this with you and to connect with you as well. And this is a document I had prepared in 2021 when I first came to Perth. So just to send out to people who are interested, but it seems to be catching on very nicely. So this is the reason for hopefully a very interactive talk where you get to ask me anything and everything that you have had trouble shooting with. So I'm here to answer your questions if I can. And I'll obviously go through these top 10 questions and some of the practice points you can initiate in the primary practice, and then and also tell you how I can help and we can work together as a team to help these patients.
So, Dr. Saha, at the moment, everyone is muted. So, do you want them to? They've got to raise their hand function so that they can ask questions, or do you want to talk about it a little bit and then open it up for questions?
No, I think the whole idea of a Zoom meeting is we keep it as interactive as possible. So I'm happy for everyone to be unmuted and ask me questions as we go along, and I'm more than happy with that.
Okay, so at the moment everyone's muted, but you can unmute yourself if you do want to ask a question. So please feel free to do that.
Sounds good.
Okay, back to you.
Okay, I guess I'll make a start then. So obviously the reason I prepared this document is from a few GP colleagues who said, can you just tell us about what we can do in primary practice on some of the patients that you deal with so that you don't have to do some of the initial work there and you can go straight on to specialist management. And this came up slowly over a couple of month period. I compiled all this. And these top 10 conditions are basically a reflection of the GP referrals that I have got, the top 10 referrals that I get in my private practice. So, and as you can see, this is something you are probably dealing with on a daily basis, all these top 10 condition. And I've also included an 11th one, which is liver. Obviously, that's a bonus. All right. So I'll move on straight to the first one, which is a chronic or functional constipation. So I'll just pull that up. Okay. I hope you can all share my screen, see my screen. Okay. So the first one is functional constipation. So as you know, constipation is a huge issue. Up to studies say up to 30 to 60% of children at some point of their childhood get affected by constipation, requiring help. And actually 30% of all my referrals are to deal with constipation and coprasis or a complication of their of constipation. And it is a tricky area and a subject to deal with because often symptoms are underreported by the children and overreported by parents, and it's all a bit mucky out there. However, the fact that it is very difficult to deal with comes from a study that showed that up to 50% of children, even after tertiary care for the management of constipation, could not come off laxative. So this was a systematic review published a couple of years ago. So 50% of children stayed on laxative after 1 year of tertiary care. That goes on to say how difficult it is to sometimes deal with and how chronic these conditions can become and how much of a burden on healthcare it is. So in terms of what I want to discuss is hopefully give you some practice points that you can initiate in primary practice, and of course, obviously, I'm there to refer if things progress beyond a certain point. And in my when to refer section, I've mentioned that obviously presence of red flags is a reason to refer straight away. But otherwise, if you are not having success in treating constipation for more than 6 weeks, would be a typical trigger for referring, so that I can have a look as well. So in terms of the practice point, and most of this is covered by the assessment side of things. I've said that distinguish between constipation and withholding, and by that what I mean is often parents will report that children cross their legs and strain, and that is not necessarily trying to poop. Uh, they might be withholding, and that is a typical withholding posturing that we do see, and that is what is called as non-retentive fecal incontinence, and that is part of the Rome 4 criteria, diagnostic criteria as well. Now, obviously, it's very important to distinguish the two, because in withholding there is obviously no constipation. The poos will still come out soft, and giving laxatives actually makes things worse, and can result in diarrhea and fecal incontinence. So it's quite important to try and get that history. And the way to distinguish it is just to make sure that the poos are still on a very regular 1 or 2 days at the most, and the stools are soft, and these would give way to a diagnosis of non-retentive fecal incontinence rather than constipation, even when they are straining very hard or seem to strain very hard. Of course, history and examination to exclude red flag, which is at the bottom of this page. Uh, and the second practice point I would like to share with you is even before we consider treatment, we must assess for fecal impaction. And what I mean by that is when the stool is when the colon is fecally loaded throughout, it is very difficult to get rid of with maintenance therapy alone. So we have to go onto a disimpaction regime, and there are disimpaction regimes freely available on the PCH website and RCH websites, where we keep on going up on the Movicol or Osmolex sachet. And and again, in terms of what makes us suspicious of fecal impaction is if there have been several days of not going for a poo, if the abdominal examination is hard, sometimes even tender, if there's fecal incontinence associated with it, and if the stools are really foul smelling. These are all very, very suggestive of fecal impaction rather than just simple constipation. So we definitely have to go through a disimpaction regime before we think of maintenance. And typically, the maintenance regime is half the dose of what the disimpaction regime needed. So if, for example, if the disimpaction required 6 sessions of Movicol, then we maintain with 3 sessions of Movicol. And the maintenance, again, something I wanted to discuss is the maintenance has got to be a good 3 to 6 months minimum, so that the bowel wall that has been stretched and is now like a deflated balloon has got time to go back into shape. And this is where obviously we can go around in a vicious circle, because if we remove the maintenance regime too quickly, because the bowel wall is very floppy and does not have a good peristaltic movements and propulsive movements, the children can get constipated very quickly again. So it's important to assess for fecal impaction and go down the correct way of management, either disimpaction or maintenance in the first instance. We always are looking for red flags. And one of the important red flags that I wanted to again mention in this talk is to assess for maltreatment. And I know in primary practice, things can be a bit tricky, but a quick, simple inspection of the anus is a good starting point, as long as you make sure that the anus is not very patulous, or and there's no bruises or injury marks around that area. It is quite a common thing actually. 1 in 6 girls and 1 in 9 boys in Australia are subject to some form of maltreatment, and a subgroup of them is maltreatment sexually. And I have seen children presenting with constipation who ultimately went on to have a diagnosis of maltreatment. So this is an important thing for us as healthcare practitioners to at least have it at the back of our mind and have a quick screen of it. And it's as simple as just having a quick look at the anus to make sure it's not patulous and there's no injury marks in that area. And one of the things that you can again do in primary practice is consider doing some blood tests, and ideally thyroid function, celiac screen, and calcium levels are the 3 most high impact blood tests that you can do in the setting of constipation. But again, I wouldn't say that that is to be done in the first instance. It is only when we are not winning for more than 5-6 weeks, then we might as well get those out of the way, especially if there are other associated features suggestive of any underlying disease process. And finally, I guess if you do have access to a continence nurse, it is very important to get that side of thing involved, just in view of the correct posturing, establishing of a bit of a bowel habit. And a continence nurse can probably follow up these patients on a more regular basis than you can as a doctor. So the family feels supported and things move in the right direction with the help of a continence nurse. So if you have somebody available, especially in the chronic constipation situations, that'll be really a game changer, and I've really been helped by that. So that is where constipation is. And so what I would do from my side after you've referred him to me is probably do the same things that you have done, just reassess everything, make sure that we have done everything that is routine in primary practice, and then move on to some of the specialist investigations such as anorectal manometry and colonic transit studies. Now, colonic transit study is a really important one because it tells me whether the constipation is normal transit, slow transit, or it's an outlet obstruction, sort of a dyssynergia of the sphincter that is causing the issues. And as you can imagine, the treatment can be very, very different in either in all these 3. In normal transit, you would give fibers and laxatives. In slow transit, we would give stimulants. We would avoid fibers because it can actually make the slow transit bowel more bulky and make the constipation worse. And obviously in outlet obstruction, we would be thinking more in terms of whether we need sphincter surgery or botulinum injection to this area. So it does change management quite a bit, and I can try some of the newer prokinetic, the bowel prokinetics like prucalopride, which have been licensed to use in children. So these are the things that I can try and do from my side if the child is referred to me. So I know constipation is a tricky area, and I'm happy to take any questions you might have on this at the moment.
If anyone wants to ask a question, just quickly unmute yourself, and then we can
Sure.
Do that.
Sorry, Cheryl, can you say that again? You got cut out.
If anyone wants to ask a question, they just need to unmute themselves.
Oh, yeah. Fantastic. So yeah, please feel free to unmute yourself and ask straight away. Let's move on to the next one.
They always get a bit shy asking questions, Dr. Saha. So yeah.
That's all good. And
but if you are shy and you don't want to ask the question out loud, you can just put it in the chat box, and then I'll ask the question on your behalf if you want to do it that way.
Sounds good.
Okay, that's you.
Okay, so I'll move on to recurrent abdominal pain. Again, a huge burden on the healthcare, and I'm sure you see a few of these on a daily basis. Um, and uh, in terms of assessment in the primary care, again, history and examination to exclude the red flags is going to be very important. However, just wanted to mention something to you. So the American Academy of Pediatrics subcommittee on the chronic abdominal pain in children came out with a paper a couple of years ago, which said that actually red flags do not, or even laboratory diagnosis and process do not reliably distinguish between organic versus non-organic abdominal pain. So we are really still not quite sure as to what is the best tests to do in these situations. And so for me, the question arises that who do we investigate? Who are we calling functional, and who are we going down the route of actually investigating all the way up to endoscopy to see whether there is an organic cause or not? And for me, so a couple of the things that really hits me is, one is the chronicity of the symptoms. If the abdominal pains have been more than 6 months, and secondly, if there's significant burden on their lifestyle, so they're missing school, they're missing their sports, so that is a big red flag for me. So for me, uh, missed school, missed sports, and chronicity of symptoms are huge red flags for me to investigate further. And I think this is something you can use in private practice as well, as some of the most potent indicators of who you should investigate further. And of course, as we all know, psychological and psychosocial factors do play a role. So we always have to keep that in mind. And there's always a bit of a dietary history that can actually give things away in primary practice. So we've all heard about the food diary, and I know that every parent and every doctor even has a bit of a different way of using and interpreting a food diary. And all I say to my patients is, in particularly bad days, just go back and write what you have eaten for the past 24 hours preceding that abdominal pain. As long as the pain is not an everyday thing, it's an intermittent thing. So just write down what you've eaten for the past 24 hours, and the parents, and I ask the parents themselves to review it and come up with anything that they think might be the trigger, rather than me getting heavily involved in that. So, and I think that gives more of a success to me, rather than me going through each and every food item on the page, which can sometimes they can come to me with thick notebooks full of information, which is impossible to review. And so again, in terms of history, constipation is the main and the most important and the most frequent cause of chronic abdominal pain. And obviously, if there's an obvious history, you can straight away treat it. But often the history is not so obvious, and it boils down to what we call as occult constipation, where they may still be opening their bowels on a daily basis, but not clearing themselves out fully. And slowly things build up, and they become impacted, and that gives abdominal pains. And I do have a significant number of children who have been referred to me with recurrent abdominal pain and was found to have occult constipation in the end. So that is something to have again in the back of the mind, that even if the bowel opening is regular, is he really clearing himself, and whether a course of laxatives, just an empirical trial of laxatives, help reduces the abdominal pain, and that is a very simple intervention that can be done in private practice. And again, I guess the main issue about constipation is this sorry, recurrent abdominal pain is for us to know, is this inflammatory bowel disease or not? And that of course, the very reliable test of fecal calprotectin is a 99% sensitive test, so that is a very important one to do. But what I wanted to again just impress upon you is that fecal calprotectin is to be done only in children aged 4 years and above. So below that age, we do not have a reference range. It's usually high, and we do not have a reference range, so we cannot interpret the result of fecal calprotectin less than 4 years. So there's no point of doing that. But of course, the other test, the stool diary, the food diary, the infection screen for stools, urine MSU, and the trial of Movicol is all reasonable steps to do in the primary practice. And in terms of bloods, again, that is going down towards the side of whether or not this is inflammatory bowel disease, is to do some bloods, including celiac screen and inflammatory markers, to give us a bit of an idea. Now,
Amit, sorry to
yeah,
interrupt. Could I just ask, the
sure.
stools that then come back with blastocystis or dientamoeba, do you
Yeah.
treat them?
So the overwhelming evidence is not to treat it, as you know, and I've had chat with the infectious disease specialists as well, that we should not be, and then their advice is we should not be treating it. So if the symptoms are short lasting, I wouldn't treat them. But look, I have treated a couple of patients with good success with a course of ciprofloxacin, and my basis again was chronicity of symptoms in the absence of anything else, even after an endoscopy was done, and nothing was found, and they continue to have abdominal pain. I gave a treatment of ciprofloxacin and they did get better. Now, I do not know whether it is these two bugs that were eliminated that caused the symptoms to get better, or we just sort of changed the microbiota a little bit with the antibiotic course that made things better. But in general, I would not treat, and the overwhelming evidence is not to treat.
Thank you.
Okay. So yeah, so we can definitely do some blood tests, and if the inflammatory markers are high, obviously it's calls for a referral. Now, a few of the other things is with regards to celiac. Obviously, I think I have got another different section on the celiac, so we can discuss that then. And Helicobacter pylori is one of the other things. Again, I do tend to do a more and more Helicobacter pylori stool antigens rather than a breath test, because in children, doing a breath test and following that protocol can be tricky and difficult, and often it comes back with like equivocal results which we cannot interpret. So the stool antigen is as good as the breath test in terms of sensitivity and specificity. So I would go with that, because then I'm not subjecting the children to a protocol that they can or cannot follow. So it's a bit unsure. And so Helicobacter is again coming up as a big thing when it comes to abdominal pain in children, because it does cause microulcers in certain children in the stomach that causes the abdominal pain in presence of acidity. And as you know, the triple therapy, the 2 antibiotics for 2 weeks and 6-week course of antacid is brilliant treatment, and it sorts out most of them. In some it doesn't. So after a course, if they are still having symptoms and the Helicobacter is still positive, then I would do an endoscopy and send some samples for a microscopy and culture, and then depending on the sensitivities, then we treat further, and that is usually
questions about how is there a age limit for testing Helicobacter in stools, or all ages? And another one is very similar from another doctor, is what is the age limit? I was told by my local pathology it shouldn't be done in under 16s.
Okay, I am not aware of any age limit. And did the pathologist mention why it shouldn't be done under 16? Because we have a huge cohort of children with Helicobacter that we have treated, and they've got better from recurrent abdominal pain. And I guess that there is still enough evidence lacking, and that is probably the basis of the pathology side of things. But when it comes to clinical medicine, it definitely works. So I
Hi, Amit.
don't have an age limit in my head. Yeah.
Sorry to interrupt. About the age limit for the H. pylori breath test, I was told the C14 was not recommended in under 16s. That's why they declined to do it. That's why I just wanted to double check from you.
Sure. So that's the breath test you're talking about.
Yes, not the stool sample.
Yeah, stool sample can be checked in any age. That's it. And like I said, I because the stool sample is equally sensitive and specific as the breath test, I would never go for a breath test. I
Okay, thank you.
wait for a stool test because it's it's not invasive and it's easy to do. So there's
Sure.
no point of going down that route. Yeah. Right. So look, the other huge issue about abdominal pain is once we have ruled out everything, and once even I have done an endoscopy and it all comes back clear, where do we go next? And this is where again the disorders of the gut-brain interaction come in, which is coming in a big way, which is what we used to call functional abdominal pain. And look, I do take a bit of an interest in this area in the sense that after the endoscopy, if everything is still negative, I know that when I was training and everything, the routine practice was, okay, there's nothing wrong with your gut, and we don't think there's anything, so we can discharge you from clinic. But I tend to hold them a little longer. I do tell them that it's a disorder of the gut-brain interaction, and I explain. I think some of the things that I do is I explain to them that the pain is very real. It is hurtful, but I reassure them that it is not harmful. And I then make a symptom-based diagnosis, and again, this is very much in accordance to Rome 4 criteria, which is a symptom-based diagnosis of functional disorder, functional gastrointestinal disorder, and it can really be only 4 types, which is functional dyspepsia or IBS or abdominal migraine or non-specific abdominal pain. These are the 4 diagnoses. So even if nothing comes out of my GI investigations, I still do end up giving them a diagnosis based on symptoms, so that parents have something to work with, and then obviously depending on the symptoms, I try and manage it with other disciplines like dietitians and physiotherapists and everything to try and sort of stay on top of their symptoms so that their lifestyle is the affection of the lifestyle is minimized. So I think that is an important area that I will be looking at in the future as well, to try and move that forward as much as possible, especially when all my investigations are negative, because again, that is a huge cohort of children who have unexplained abdominal pain at the end of every investigation. So would love to have again any questions or thoughts you might have or any experience.
So, Dr. Saha, can I please ask? A lot of people, they come in and they say they're malabsorbing, or they talk a lot about lactose and fructose, and then there's some special tests. I know some labs offer them. They're expensive. What's your thoughts on that?
Again, I would go more in terms of a symptom-based diagnosis, in the sense that when we use the food diary, and if it is used properly, it might well identify those things. As you know, the fructose and the lactose is really to test for the genetics of the lactase gene that will present in babies. So there's no point doing it later on in life. That does make sense. And for the fructose breath test, more reliable than the breath test is an exclusion diet. So that will be on the basis of their food diary.
Okay.
So the fructose test can often come negative when they are fructose intolerant. So its specificity is low, its sensitivity is unreliable. So I would go right down an exclusion path rather than go for these tests. So not a usual test that I end up doing.
Okay, thank you.
Okay, right. Okay, we move on to the next one, which is failure to thrive. Okay, again, a lot of children, and I'm surprised that a lot of babies under 1 year get referred with failure to thrive, which is quite common. And again, there's lots that can be done in primary care, and essentially I do only one thing in as a specialist. So I'll just go through with you. I guess the first thing to say is that the first 3 months, it can be a bit of a correction phase for babies. So the first 3 months, they can move a little bit down on the centiles before they reach their destined centile, and then they plod along nicely along that. So I wouldn't I would sort of reassure them that as long as they are gaining weight, even if they do cross 1 or 2 centiles in the first 3 months, I wouldn't rush in to investigate anything. I would reassure and just bring them back in clinic for a repeat anthropometry. Now, beyond 3 months, if they have crossed 2 centiles, of course, that is a bit of a trigger for us to investigate. And the way I see it is there is only 4 things that can go wrong, only at 4 levels. One is inadequate calorie intake, where we can quickly sort that out by taking a history. And if there is any doubt, we can refer to a dietitian, not only to optimize their calorie intake, but also to sort of give them a bit of a diet plan that gives them catch-up growth as well. So a dietitian will be a very useful tool in this situation. And just to mention that 90% of all children who are referred to me with failure to thrive do end up having a calorie intake problem, one way or the other. The second one is obviously an excessive issue, where there is an obvious chronic diarrhea or chronic vomiting in that respect. So again, this is easy to see that they are losing too much, and we have to go down the route of investigating that cause as to why they're having chronic diarrhea and chronic vomiting. And then the third thing is excessive consumption of calories. And I guess this is an important one to rule out in primary practice. And I think a common one is cardiac, the undiagnosed heart issues, and they will usually have a florid murmur that you can hear, or some other signs of chronic illness, and a quick blood screen should pick up most of these, including celiac disease, inflammation, nutritional deficiencies. So a blood test like the ones mentioned should pick up any chronic underlying disease process. And finally, this is where the fourth issue that can cause them failure to thrive is an absorption issue, such as any congenital enteropathies that is undetected, or things like celiac disease or chronic gastritis. So an absorption problem that can only be picked up on intestinal biopsies. So this is where I would come in. So as long as we have assessed the calorie intake side of things, we have made sure there's no excessive loss, and we have made sure that there's no excessive consumption of calories in the body by other disease processes, I think we should sort of have seen through 95% of failure to thrive infants and sorted them out on these 3 lines along. And then if we are still not winning, then obviously they would warrant an endoscopy, where I would come in and get that done. And again, I've included some signs and symptoms of underlying medical causes, which obviously you are all aware of. And I think in terms of further management, if there's an underlying absorption issue, there are all sorts of considerations, whether they need an inpatient admission for nutritional rehabilitation, whether they need refeeding bloods to be done on a daily basis, whether they need parenteral nutrition. So there's all sorts of considerations that needs to be looked at, but these are obviously only 5% of the kids. But like I said, 95% of the ones we should be able to sort out in primary practice, and I'm more than happy to liaise with individual children and try and get that sorted at a primary care level. Okay, right. Any questions? Otherwise, I'll move on to the next one. Right. So gastroesophageal reflux and chronic vomiting. I guess, again, you must be seeing a few of these every day. I guess the first thing to mention in kids is that in the first year of life, we consider this as physiological. So the gastroesophageal sphincter is not developed and tight enough in the first year of life, and therefore reflux is physiological. The question is, how much of an acid reflux is happening, because a lot of it can be non-acid, but obviously if this is acid reflux, it will be associated with quite excessive symptoms, and the baby's crying and arching their back and all sorts of symptoms. Now, again, in primary practice, we we can definitely bring in some lifestyle modifications straight away, again, in infants and older children as per this management options. And if there is a lot of distress associated, it is not a problem to start trial an anti-reflux medication and PPI for about 6 weeks. As you know, esomeprazole is licensed for children under 1 year of age. So trial of esomeprazole, but as long as we keep it between 4 to 6 weeks time, because the issues with PPIs will come into play only when it is used long term. A short term PPI course is very safe. So, so that is something we can do. And the idea is that after a short course, it heals up any reflux esophagitis that they might have, and then they are able to tolerate the acid reflux much better. So, so even if they do have reflux esophagitis, a course should sort it out, and they should be able to tolerate it after that, and they do not necessarily need a long course then. So we can reassure parents that it doesn't mean that they're going to stay on it forever or anything like that. So that is a good option to do. And I guess in food refusal and children who vomit, it is important to rule out anatomical causes and also eosinophilic esophagitis. And I've got a separate one on eosinophilic esophagitis, so I'll talk about that. But food refusal and fussy eating is in children aged less than 1 year is a sign of eosinophilic esophagitis, should raise that possibility. And again, I think in my last 2 years in Perth, I have diagnosed at least 15 to 20 babies with eosinophilic esophagitis who are less than a year old. So it is very common in less than a year old as well. And in terms of ruling out anatomical issues, if they have chronic vomiting, I would normally tend to do a very quick barium swallow and follow through, just to make sure there's no strictures or malrotations or anything. And of course, in chronic vomiting, we have to consider cow's milk protein allergy, which I will talk about separately, and then go down the route of eosinophilic esophagitis, at least to rule it out and make sure that we're not missing that as a cause. But in terms of simple acid reflux, the most important consideration at primary care is, are they losing weight with it? And that is a big red flag. And this is where the term gastroesophageal reflux disease come in with weight loss. But if it is gastroesophageal reflux, we're just going to call it physiological. If the symptoms are bad, we consider a trial of PPI. But otherwise, if they have not lost weight, I think a reassurance of parents, as long as they're under a year old, should be the way forward. Okay. And lifestyle modification. Sorry.
There is a question about PPI. What is the youngest age you would try PPI on a patient?
So in terms of PPI on patient, when I was working in neonates, we were even using PPIs in preterm babies. So I guess there are some, these are obviously off-label uses. So there's no minimum age as such, as long as we do a reasonable dose, which is 1 to 3 milligrams per kilogram. And we have a short course, and we have an end date to that course. But like I said, we use PPIs even in preterm neonates, so there's no minimum age. Okay. So and then in terms of me in clinic, I have used it in all ages, right from the age of 1 month old. So it's not uncommon even for an oral PPI to be used. We can sort of mix the esomeprazole granules in water and give them, and with good effect. Coming to house milk protein allergy. Right. Again, the important thing to consider here is, as I said in the assessment, is to consider lactose intolerance as a possibility. And as you're aware, it's important to make that distinction, because we have to find out, is it the protein which is the trigger, or is it the sugar which is the trigger? And in terms of symptom differences, cow's milk protein allergy will involve other body systems, such as skin rashes and everything, whereas lactose intolerance will be limited to the GI symptoms only. So vomiting, diarrhea. It would be limited to vomiting, bloating, abdominal pain, and diarrhea sort of a thing. It will not move to other systems. So if you do see skin affections and everything, we are not dealing with a lactose intolerance anymore. So this is where, and the other important clinical distinguisher is whenever we talk about a trial of either cow's milk protein-free diet or lactose-free, if it is lactose intolerance, a lactose-free diet will have a very good effect within 48 hours. So it's a quick turn. Whereas cow's milk protein allergy, we have to trial a minimum of 6 weeks before we see a benefit. So there's another big clinical difference between cow's milk protein allergy and lactose intolerance. So, and as you know, the other big difference, I guess, is cow's milk protein allergy is uncommon to present itself beyond a year's age. We are invariably looking at lactose intolerance or secondary lactose intolerance beyond a year of age. But if it is a child or a baby under a year age, we have to consider cow's milk protein allergy as well. Extensively hydrolyzed formula is the first line. There is no role of partially hydrolyzed formula. And so the first line treatment is an extensively hydrolyzed formula along with the help of a dietitian. And I've mentioned the Askia website because I have found it very, very helpful in terms of looking at what are the milk alternatives, what are the diet alternatives. It is an absolute treasure, the Askia website, and I would definitely recommend you guide your treatment plans on that basis and show the patients that website as well, so that they get a lot of knowledge and information out there from there. Now, in terms of a gastroenterologist, again, if the cow's milk protein allergy is severe and they do not tolerate extensive hydrolyzed formula as well, we have to go on an amino acid formula and get a dietitian involved. But the good news is most cow's milk protein allergy children do grow out of, and 95% will grow out of it. And it'll be important to get a dietitian involved in terms of getting them back on dairy using the milk ladder, where we go up slowly and introducing one thing at a time. And I guess the other thing to mention is soya, which has got a 20% cross reactivity with milk protein. So I do end up seeing patients where they have been diagnosed with dairy allergy or cow's milk protein allergy, but they are on a soya milk and they are continuing with the symptoms. And as soon as I stop the soya milk, that things improve. So I always go for a dairy and soya free. It's in the same breath because of the 20% cross reactivity chance. So I would never go with soya if they are dairy intolerant. And it's very unusual to go for a gastroscopy or a colonoscopy in dairy intolerance unless they're really unwell and losing weight and we have a diagnostic dilemma, are we missing something? But otherwise, hopefully we don't need to go down that route. Okay, and I've mentioned about the Askia website here and some practice points in suspected CMPA, which are all very, that I have found helpful. Hey, no questions. Moving on to the next one then. Celiac disease. Okay. And again, I think you're all very experienced in this. The history is very typical: chronic abdominal pain, chronic diarrhea, and fatigue, sometimes headaches, psychological issues. And as long as we discuss them on the basis of high risk associations, which are at the bottom of the page, which are family history, autoimmune thyroid disease, or any other autoimmune diseases really, and Downs and Turners, we usually test them for celiac. And I know we normally tend to do a celiac serology. Now, and there are these other blood tests, the EMA and the HLA, which is the genetic testing. And I just wanted to touch upon these. So obviously the TTG IgA is the most sensitive and specific one, and the one we do. and one we depend upon for a celiac screen. Now, obviously, it will depend on the IgA levels. Some of the labs don't routinely do an IgA level with it, which is a bit funny, because that we do know that at least 7% of the general population have got IgA deficiency. So it's important to know whether they do have an IgA level that is enough to raise that response of a TTG IgA, otherwise it's an unreliable test. So I always try to make sure that an IgA level is done, and if not done, I get it done separately, just to make sure that the test is reliable. And because of this IgA deficiency risk, we do end up doing a DGP IgG level as well, most celiac screens. But we have to remember that this is a very non-specific one, and it does get raised in a lot of other conditions as well. So it is not a very reliable test on its own. And I know that PCH doesn't actually recommend anybody for an endoscopy on DGP levels alone, unless it is repeatedly less and the symptoms are very, very suggestive. Now, as you know, that there is a non-endoscopic diagnostic pathway as well, which is the ESPEGAN 2020 criteria, the European criteria. And that criteria will come into play only if the TTG levels initially are more than 10 times raised of the normal levels. So a TTG of 100 and more we should be considering a non-diagnostic approach. And essentially, it's a second blood test with an EMA positive that leads to that diagnosis. Again, if that is the situation, the normal practice would be a diagnosis by a gastroenterologist, so that we can follow things up as well and do other autoimmune screens. So if you do have a TTG of more than 100, the best thing would be to refer it to me, so that I can make a formal diagnosis and screen for other autoimmune conditions as necessary. But obviously, otherwise, if that is not possible, if the TTG is slightly raised but not more than 10 times, a formal endoscopic diagnosis is always the way forward, which is the gold standard in Australia. And in terms of the genetic testing, as you know, the HLA-DQ2 and DQ8, there is no role in the diagnosis of celiac disease, absolutely no role. Even if both the genes positive, it does not mean anything. However, there is a very important role of the genetics, which is in situations where the child is already on a gluten-free diet for some time, and we want to know whether there is underlying celiac disease and he has never been tested. So obviously all the other tests will be unreliable, but the genetics will be very reliable, in the sense that if both the genes come back negative, there is a 99% sensitivity that it is not celiac. So it is a negative predictive value only. So it's got nothing to do with diagnosis of celiac disease. It rules out celiac disease with 99% sensitivity. So that is where I use the genetic test, and that is the only situation to use the genetics test. Okay, and of course, they must remain on a gluten-free diet till all a formal diagnosis, one way or the other, have been made. Otherwise, obviously, we have to reintroduce gluten into them, which is something that parents don't like at all. Okay, so and I do follow up celiacs for some time because after a gluten-free diet, I do further tests to rule out associated autoimmune diseases with blood tests and clinical examination, just to be on the safe side, and before I discharge them back to your care. So I will do all the workup, including other autoimmune workup, before I send them back to you, and with a plan for surveillance going forward. So that's pretty much celiac disease. Is there anything you wanted to ask? Okay, moving on to eosinophilic esophagitis. Again, coming up with
one question, sorry, just come in. Which
Sure.
blood test should we do, and how frequently once diagnosed celiac are on a gluten-free diet and symptom-free?
Sorry, you broke up a bit. Can you repeat the question, please?
So which blood test should we do, and
Yeah.
how frequently once they're diagnosed as a celiac, and then it's for are on gluten-free diet and symptom-free?
Fair enough. Yes. So the normal screening blood test is a TTG IgA again, as long as they have a normal IgA levels. So and then obviously it should come back negative every time if they're compliant. So it's a TTG IgA for surveillance. And as long as the TTG IgA levels are less than 7.
Excellent. Thank you.
Okay, lovely. So suspected EOE, again, the very, very typical history is the retrosternal chest pains during eating. And they can sometimes present as a food bolus obstruction. Obviously, if there's a food bolus obstruction, it's a ED situation. They have to go to emergency department and get an emergent endoscopy done. But the chronic history of retrosternal chest pain while eating, food getting stuck in the throat. I often have to drink water to gulp it down. These are the typical symptoms and that they will report back. And regurgitation is also a very common symptom where they will say they have to swallow back their regurgitate very frequently, especially during meals. And the typical child is the one who's also got other atopy history associated like allergy, eczema, and asthma. And there may or may not be a family history as well. So here, unfortunately, the referral is straight to me because the only way to diagnose is it on biopsy. So we tend to see more than 20 eosinophils on every high power field on the histopathology, and that leads to the diagnosis. And the way we differentiate it from reflux esophagitis is because it's a pan-esophageal affliction. So both the upper and the lower esophagus is affected equally, whereas in reflux, it's only the lower esophagus which has high eosinophil counts, whereas in eosinophilic esophagitis, the whole of the esophagus has high eosinophilic counts, and it loses its motility, and therefore the symptoms of this motility that is present, including regurgitation and chest pains. And in terms of treatment, there is a small subgroup of children who respond to PPIs, and they are called as PPI responsive eosinophilic esophagitis. And then, but the vast majority, it is going to be dietary intervention, and there are targeted elimination diets, 2 food elimination diet, 4 food, 6 food. So there's all sorts of elimination diets that are present in the guidelines, depending on what we see and what the history is and what the suspected triggers are. And of course, there are steroids that can be used as well in the long-term situation, and especially if there's severe dysphagia or adrenophagia, we can do a top-down approach and start with steroids, get on top of the symptoms before we go down the dietary pathway. So there's different treatment options, but obviously we need a diagnosis first. So a quick referral and a quick endoscopy would be the way forward in these situations. Okay, you can start them on a PPI because, like I said, PPI should even if we do the first endoscopy on a PPI, there is a management pathway through that as well. So if you think that they are very symptomatic and there's a 6 weeks waiting period or something to see a gastroenterologist, then you can safely start them on a PPI in this situation, and that's not unusual at all. Okay. Okay. Any questions on eosinophilic esophagitis? So I'm aware of the time, so I'm moving a bit quickly now. Chronic diarrhea, and the definition is ongoing diarrhea over 2 weeks. Obviously, one of the important histories to take is travel history. But of course, again, in the back of the mind, we should have is are we dealing with an IBD, inflammatory bowel disease? And apart from the blood test, we definitely must consider fecal calprotectin, and also all the infective screen, because even before an endoscopy is recommended, we should have a infection screen negative before we proceed with an endoscopy. And again, I guess it all depends on the endoscopy whether we find evidence of inflammatory bowel disease or allergic colitis or or colitis for any other reason, like microscopic colitis for any other reason. So it is heavily endoscopy diagnosis finding, but often again, endoscopy can be clear, where then we can move back to whether this is a dietary thing, and we need to intervene with sort of a dietary approach in terms of either dairy-free or gluten-free, which are the typical triggers. Now, I just wanted to quickly mention with regards to gluten-free, there is a huge cohort of children with non-celiac gluten sensitivity, and these are the ones where they are very sensitive to gluten, but they do not have celiac disease, and which is clarified with an endoscopy or blood test. And I always tell these families that it is very, very different to celiac disease, because although you still probably need about 1 to 2 years of gluten exclusion for this to get better, it is not a lifelong condition. It is not autoimmune driven. So they will grow out of it, just like other allergies. And the idea is to try and challenge them with the gluten again in a year's time, to see if they can tolerate it again, which is which is a deviation from what we would normally do in celiac, where it is for life. So it's important to make that distinction whether they have celiac or non-celiac gluten sensitivity. Okay. So moving on to the next one, GI bleed. So obviously in the primary practice, the main priority is, sorry, question. Okay, so the main priority is the hemodynamic stability. Do they need an emergency admission and something? But more often than not, they will see you in clinic with long-standing either hematemesis or melena, or even hematochezia, fresh red blood. And again, fecal calprotectin would be a good starting point, as long as they are over 4 years, and blood tests to do. And again, the overwhelming priority is to look for IBD and to rule it out. Now, the other big reason why children have rectal bleeds is a polyp. And in either situation, they will probably end up needing a colonoscopy to rule out things one way or the other. Okay, so sorry. So I guess as long as they are stable, blood tests and fecal calprotectin would be the way forward in primary practice, and if they have rectal bleeds, to refer them for a colonoscopy so that we can have a look. And finally, I think we have spoken about this quite a bit already, is suspected IBD. And I guess an important thing is to look for extraintestinal manifestations, like have they got mouth ulcers, or have they lost weight, and then that all that would determine the urgency of the referral. Again, we should be doing blood tests and fecal calprotectin and stool for infection even before referral, so that these are all in place. And I would normally prioritize these kids for an endoscopy, gastroscopy, and colonoscopy, and look for all other complications associated with it. As you know, this is a multidisciplinary management, so I would often get the hospital side of things involved as well, because it is, at the end of the day, a multidisciplinary management with the dietitian and IBD nurse and everybody. And they will need long-term and lifetime really follow-up and surveillance endoscopies and management in an IBD clinic setup. And last but not the list is the liver disease. Sorry, it's not rolling forward. Yeah. So again, in terms of a liver disease, I guess the most important thing to mention is, more often than not, you will have raised transaminases as presenting in the GP surgery, just with the AST and ALT levels raised. Now, if it is a obese child, more likely than not, the underlying diagnosis is going to be fatty liver disease or NAFLD. Now, it is quite important to sort of recognize them the non-alcoholic fatty liver disease kids, and to have a very strict monitoring and lifestyle modification regime on them, because the only treatment for this is a liver transplantation. So it is a big deal, and we are ending up transplanting a lot of livers for children with NAFALD, and by 2024 it is actually predicted to be the leading cause of liver transplantation in kids. So it is that bad. And as we know, obesity is rising, and this is a huge issue. So more often than not, they will just have raised AST and ALT in the setting of obesity. But I do have a bit of a liver screen or a panel that I do just to rule out any other causes, and that is at the bottom of this page. And this is something you can initiate from primary practice as well, as long as this panel is normal. We are reasonably, in the setting of obesity, we are reasonably sure that this is NAFALD we are dealing with. Now, the gold standard of diagnosis of NAFALD is a liver biopsy. But in my experience at King's College Liver Unit and in Royal Children's Hospital, we don't necessarily go down that route, because it's just a mental satisfaction and confirmation of diagnosis really on the liver biopsy. We do see some degree of hepatosteatosis on the biopsies. So all we tend to do is, as long as we have not, as long as we have ruled out other liver issues with that liver panel, as long as there is obesity, and as long as it's transaminitis only, then we safely manage them as likely NAFALD with strict lifestyle modification. And as you know, the only two interventions is diet and exercise. And so what I tend to do is there are apps available where they can really monitor their diet, exercise, and their weight, and then that gives them a bit of a sort of a direction where they can go, and some incentive to do things. But from my side of things, I say that I would see them every 4 to 6 months for repeat anthropometry, and I make them a demand that I would want to see some weight loss and some more diet and exercise every time they come in, and the liver numbers coming down as they do that. So incentivizing them is a good way of doing this, and sometimes just telling them how bad the disease can be, and how bad the complications can be, can help in older children, which is nothing but scare tactics, but probably sometimes it helps as well. So I again tend to follow these children up after I've ruled out other liver issues very tightly, because NAFALD is becoming an increasing population, and often they would have some degree of metabolic syndrome with them, with high sugars and stuff like that, which is also to be managed, and I would liaise with my other colleagues, the hematology colleagues, or endocrine colleagues to manage that optimally, the metabolic syndrome side of things. Again, something that needs a real tight follow-up in liver disease in children. All right. Any questions from your side?
So I've got a couple of questions. One was that does dietary elimination for EOE include allergic foods? The first one.
Yep. So does dietary elimination include allergic foods? That's the whole idea is that it is an allergy driven process, EOE. So as long as we have identified the allergen, we eliminate that, it should get better. So the answer to your question is yes. If we remove the allergen, and which is often a dietary cause, they get better, and we have a repeat endoscopy as a confirmation for that. Yeah.
The next one is how do we differentiate osmotic diarrhea from secretory diarrhea, which tests are available in GP setting?
Okay, so in the GP land, I think the very simple and quick test to do in this situation is to, I wouldn't say in the GP land we have to admit them to hospital. The easiest test is to stop feeding. So an osmotic diarrhea if we don't give them anything in through the mouth, it will stop, whereas a secretory diarrhea will continue. So that is the easiest and the most effective clinical way of diagnosing it. Now, in smaller children, obviously, we have to admit them to hospital and give them IV fluids when we run this situation. But I guess in older children, you can ask them, just have drinks for a day, do not eat anything solid, and that can give you a clear indication of what you're dealing with.
And the final question I've got is, what tests do we do for protein carbohydrate malabsorption?
For protein carbohydrate malabsorption, it's probably, again, there's no test that is very reliable. Elimination diet would be the most reliable thing. Now, there are a few disaccharide disease tests that we can do and test for in endoscopy, but it is very unreliable, and most gastroenterologists wouldn't end up doing it on a routine basis, and it is usually useful only in babies under a year of 1 year. So for protein malabsorption and carbohydrate malabsorption, there are again a couple of stool tests as well, but they go off site, and